So I guess you can all see my slides now. Okay, so I prepared about 40 minutes, 45, and then we can leave at the end for questions, discussion, if you have any questions, okay? So the talk that I'll tell you today is about Project ECHO for paying in Canada. What's going on? So I'm here, I'm that red dot there in Toronto, and you're very close, but Canada is a very large country, as you know. I don't have any conflicts to declare. So about Canada, we're all Canadians and we know a little bit about Canada, but one thing that we might not know is how many people live in areas that are very low in density population. Many Canadians, even though they may live in an urban area, this doesn't mean that they have access to a specialist. It doesn't mean that they have access to a pain clinic or to a hospital that can offer interventions. So, because a lot of people live in the south border of Canada, but look at the size of Canada, there are still a lot of people living in those areas, and those are very sparsely populated. And the population of Canada in the last, this is already almost 20 years outdated, we know that 80% now live in urban areas. But again, it doesn't mean that in an urban area they have a pain clinic. It doesn't mean that they have a specialist in pain where they live. Most people don't. And we know this because people in rural, remote areas have difficulty to access a specialist, especially chronic pain specialist. And not only this, but those also, they are the most disadvantages. So there's a big inequality in care because what they can access for pain care, not only for diagnosis, but for treatment. So many disadvantaged patients who live in rural areas and underserved areas are not receiving the care that they need because they cannot afford traveling. Also, those areas, they usually find it's very hard to recruit and retain specialists in those areas, which is another problem. How are you going to recruit specialists to work with those areas? So we published a paper in the Canadian Journal of Rural Medicine last year talking about the problems of healthcare in rural, remote, and underserved areas, and then we talk about Project ECHO. So you may think about, is telemedicine the solution then for the rural, remote, underserved areas? So what is telemedicine? I still do telemedicine. I'm not saying that ECHO is a substitute for telemedicine. I do both. Telemedicine is bridging the geographical barrier. Telemedicine is, here you have the specialist and here you have the patient and they are distant, and you are then connecting both via a camera, a telephone, a video conference. But you have to think about this. When the specialist is seeing the patient via telemedicine, that specialist is not actually providing care in where he or she works, right? Because that person was supposed to be working and doing research and seeing other people, and they are not. So it's really time consuming to do telemedicine because I have to stop doing my clinic, go and connect and see a patient. So what is ECHO? So ECHO versus telemedicine, here is an expert hub. So here are the experts, and these are a group of experts, could be, you'll see what is our hub. And then these experts will be teaching, mentoring primary care providers in those rural, remote, distant areas. And those primary care providers then will see patients now with the knowledge that they have, but it's not just knowledge that we give to these primary care providers, it's a lot of skills, it's exchanging experiences. So it is more complex than just a webinar or a workshop. I'll explain to you why. So people need access to specialty care for complex health conditions, not only pain, but you can imagine all the health care that can be complex. They need complex specialist care. And there aren't enough specialists. Even if all of us specialists, we would be doing telemedicine to reach all of these areas around us, we would have to stop what we are doing in our regular clinic to provide telemedicine because we aren't enough. There aren't enough specialists for everyone. So what we do is we train and support. It's not just training, but it's supporting. We don't want the primary care. We know the primary care provider is never going to be a specialist. That's not the intention, that the primary care provider, the family doctor, the nurse practitioner, the pharmacist will now become a specialist. No, because I do specialist care. I only see those things. I only see chronic pain. They see a lot of things. So I can't expect that they are experts, they will be specialists in everything that they see. But what we want is that those primary care clinicians, they will provide care at the best of their competency and scope. That's what we want. So this means that more people will get the care that they need from a primary care provider that is competent and is practicing at the best using all of their scope of practice. So patients end up receiving the right care in the right place, where they live, at the right time. So this improves outcomes and reduces costs. So, oops, I went too far. It was supposed to be, sorry, went too ahead of me. Okay, so we are here. What is ECHO? So a typical ECHO session looks like this. This was before the pandemic, where this is our team of experts on the left side. And what we were doing here is we were all together in the same room before the pandemic. Now, each one of us, we are in our own homes. And so we were connecting. This is an ECHO session. We connect via Zoom with a team of primary care providers all over the province of Ontario. And what do we do during this 90 minutes? They present their cases to everybody. It's not just the primary care providers presenting their cases to the specialists and the specialists tell them what to do. That's not how it works. They present a case and then everybody asks questions, including their colleagues in primary care. And then we open for recommendations, and always the first people who ask questions and the first people who make recommendations to that case is always the primary care providers. And we, the hub of experts, we are there to watch, to correct if there is any misconception. We are there to complement the information that has been said, but most of the time, whatever the primary care providers are saying is correct, and we need to reassure them, and then we complement what they didn't say. So we have interprofessional team here, and we have interprofessional people in the audience, and we all learn and we are all teaching. This is a typical ECHO session. So here is like the specialist team in the middle, and we are exchanging knowledge. Again, it's not just the experts teaching the primary care providers what to do. It's everybody learning together. And they teach, they talk about their cases, they talk about their challenges. And sometimes I don't have the solution. It's going to be another primary care provider in another place of Ontario who has an idea how to help that person with that patient. The patients are never present in the session. The cases are anonymous, de-identified cases. So our audience is basically that primary care provider who is presenting the case. And because our cases of chronic pain are so complex, we are able to just do one case per session. So we dedicate about an hour discussing one case and 20, 30 minutes having a didactic presentation given by one member of the specialist team. And those didactics, they follow a curriculum. I'll show you what is our curriculum, the topics for our curriculum. But here you can see, we use this force multiplication. It's a concept used in the Army that you can force multiply your strength. And so we can see, look at the size of the expert team and look how many patients now are being impacted by the knowledge of the specialists. So it's a group, a network, a community of practice where all teach, all learn. So I'll give you an example. when I started ECHO in 2014, I thought that I was coming to teach them. You know, I wrote the guidelines, I know everything about the guidelines, the opioid guidelines, so I'm coming to teach the primary care providers. What a lesson on humility, because I learned much more than I teach. So this is a a primary care site in Sulucaut. It's a very, in the middle of Ontario. It's a very rural indigenous populations, and this is the Menoya Wing Health Center. We had a family doctor who works in this center, and she presented a number of cases. So one case that she presented, it was a woman, and I was facilitating the session that time, so I remember the case very well. And this lady was using opioids on a high dose. Her husband also was an opioid, so they were sharing their opioids, and she was losing control. Clearly, the patient was losing control how much opioids she was taking. But when the family doctor presented the case, we all realized that the patient still needed opioids. So someone suggested to this primary care provider, why don't you put her on buprenorphine naloxone? And she said, I don't know how to do this. And so then we discussed, Andrew Smith is an addiction expert in our team. So he gave her a brief explanation how to do a Suboxone induction. And then after the session, he picked the phone and guided her how to do it. So then 2-3 weeks later, she came to present another case. And then she said, can I present a follow-up on that case that I presented a couple of weeks ago? We always love follow-ups. So she said, that case, that woman is doing amazing. I did the Suboxone induction under Dr. Smith mentoring. The patient now, her pain is much better, well controlled, and all the problems that she was having with the opioids have stopped, and the patient is so grateful, and I'm going to do this more often. And then I thought to myself, Andrea, you don't do Suboxone induction because you don't know. And this person in Sulucaut has learned in ECHO. Why don't you go and learn yourself? So then we hired one specialist to come and teach our pain clinic. So this was about 2-3 years ago, and that's when we started doing Suboxone induction, and it has been great. So I learned from the ECHO community why they were doing it and I was not. So this was just an example how we have all of this. I'm always constantly learning and implementing some new things in my practice because of what I hear and learn in ECHO. So ECHO moves knowledge. We're not moving people. Everybody is where they are, and we are moving knowledge where knowledge needs to be. So when we are trying to recruit participants to come and present their cases of ECHO, because they have to give us their time, right? It's almost being there every week for 90 minutes for many, many weeks. They don't pay anything. We don't pay them to be there. So why are they coming? Well, it's free for them because it's funded by our Ministry of Health. It's virtual, so they can do from anywhere in Ontario. It's fun. We make those sessions, we make jokes and we make it like a light. We are teaching, but it's also fun because we celebrate, we give gift cards and we celebrate, we do awards, and then they also get CME credits for the sessions that they participate. And we know it's working for our healthcare system. So we are helping our patients to have a better life. So a little bit about Project ECHO in the world and how did it start. So this is the founder of Project ECHO, Dr. Aurora. And I invited him to come here. So I'll let him introduce himself and explain to you why he had the idea to start ECHO. So let me see if the video works. Yesterday it did work.
There is a specialist shortage worldwide. We had to innovate a new model.
Andrea?
Project ECHO allows specialists like me.
Yes.
Sorry, it's not popping out like yesterday. Let's retry it.
Okay. We'll try again, no problem. Oh, I know why. It's because I'm not sharing my whole desktop. Okay, I'll share my desktop. Okay, is the video there?
That's better.
There is a specialist shortage worldwide. We had to innovate a new model. Project Echo allows specialists like me to force multiply expertise. I think that's why it works, because it's very simple. And that's actually why I could come up with an idea like this, because it was simple. In 2003, there were 30,000 patients with hepatitis C in New Mexico. I didn't have enough time to see everybody. And that led to a lot of soul searching. What is the way that I can have a bigger impact than the patients whom I just see in my own clinic?
Well, the 1025 was 10.
It just came as an idea. Skype was available. I talked to my daughters on it. Seeing this technological revolution unfold was probably a background knowledge that I needed to come up with this idea. In 2010 alone, we have trained more than 1,000 healthcare clinicians on our video conferencing platforms. Nurses, primary care doctors, physician assistants. Uniformly, every single echo project that we've started, the specialists find it extraordinarily rewarding sharing their expertise to improve the health of underserved populations in the United States and ultimately all over the world.
Okay, so back to my slides. So this is Dr. Aurora, the founder of ECHO, as you heard. So when you saw that he treats hepatitis C patients, and he was the only hepatologist in New Mexico in 2003, and there were 30,000 people infected, and that's how he came with the idea. But really, ECHO exploded in the world when he published this paper in the New England Journal of Medicine. So he published a comparison of the patients that he treated in his academic clinic in the university, and the specialists. Patients had to travel from all over New Mexico to come to his clinic in Albuquerque for about 18 months. That's how the duration of the treatment was, and they had to take ribavirin, interferon, and these treatments can kill the person, right? Fortunately, now we have better treatments, but at that time, that was what they had. And so you had to convince people to take the treatment because they were not feeling anything. Just because they had a blood test that shows that they had hepatitis C, now they have to have this horrible treatment for 18 months. So the GPs, who are not even family doctors, GPs are people who just have medical school, they didn't do residency in family medicine, they were really afraid of touching people and doing this treatment and could kill the patient because the treatment had serious side effects. So with ECHO, Dr. Aurora convinced them, these GPs, that under Dr. Aurora's guidance and mentorship, these GPs in rural areas of New Mexico could start treating people with hepatitis C. So when he published, the results showed that cure rates were the same in rural areas of New Mexico and in his clinic. So here is the ECHO sites. And you can see that ECHO sites, they also treated more patients than Dr. Aurora. They treated 261 and 58% were cured. Dr. Aurora, during the same period, treated 146 and 57% were cured. So no difference in cure rates. If this was on itself not amazing, this is already amazing because these 261 people would never have received treatment if it was not for ECHO. Look at the size of the adverse effects. So this is the table in the paper of serious adverse effects, and you see that there is a p-value that is statistically significant because the ECHO sites had half of the serious adverse effects that Dr. Aurora had. So not only they achieved the same efficacy, but they were better than Dr. Aurora in terms of managing adverse effects. So when Dr. Aurora published this in the New England, there was an explosion. People wanted to know, come to New Mexico to learn what is this thing called echo, because in New Mexico at that time in 2011, they were already doing echo for hepatitis C, substance use disorder, chronic pain, rheumatology, diabetes, etc., many, many different things. So the mission of Project ECHO is to expand the capacity to provide the best practice care for common and complex diseases in rural and underserved areas and to monitor outcomes. It doesn't mean that primary care providers in downtown Toronto cannot present cases to our ECHO. Actually, we have people who are practicing in Toronto and they are our ECHO community of spokes because they want to learn how to provide care to their patients without having to send them to these specialist clinics. So I had to update this slide yesterday because I had given this talk two months ago and it was already outdated. So this slide almost has to be updated every day. There are now 44 countries doing ECHO. There are 423 hubs all over the world, and there are more than 920 programs all over the world. And you name a disease and you can find an ECHO for that disease. And there are things, ECHO for cancer screening, for nursing homes. Actually, just President Trump just gave $250 million. It's 1/4 billion to ECHO to tackle the problem of COVID-19 in nursing homes in the United States. But there is ECHO for everything. You can do ECHO for a number of things. So here is the AHRQ, where President Trump gave this money to do the ECHO nursing homes, COVID-19. Project ECHO is one of the 6 finalists for the MacArthur Foundation grant to get $100 million to improve the lives of people all over the world. And in India, really, ECHO has exploded in India. There are more than almost 400,000 healthcare providers who had been already trained in ECHO. So they really expanded ECHO for a number of different diseases all over India because it's funded by the government in India that they can get training via ECHO. So this is ECHO Global. What are we doing in Canada? So this was my partner in crime, Dr. Ruth Dubing, many of you know. And so this is, Dr. Dubing is a family physician from Kingston, Ontario. She's now retired. And she's the one who went to the States and she found Project ECHO there. And she came in 2013 and said, we need to bring ECHO to Canada. So we partnered and we had to convince and we had to find, where can we have a house for Project ECHO? Where can we go? And so we found UHN is the hospital where I work, was very well open for us to do ECHO there. And then we started. So I started with an interprofessional team. This is our team of experts. We have myself, physiatry, pain medicine, addiction medicine, neurology, family medicine, and psychiatry. These are the medicine professions. And then we have the non-medical professionals, psychology, nursing, occupational therapy, physical therapy, pharmacy, social work, chiropractor, and we have an embedded clinical librarian in our hub. So we already trained more than 500 sites. It's not even close to what India has done. They trained almost 400,000 people there. We trained 500 sites. Some sites have more than one healthcare professional. But you see that the people who came to our program and already graduated, they are from all over Ontario, including many areas in the north, southeast, northeast, northwest, which are areas of where there is a poor access of pain clinics. Who are they? They have we have approximately 1/3 is physicians, the other 1/3 nurses and nurse practitioners, and the other group is a mix of pharmacists, mental health professionals, rehabilitation professionals. So you see, we have an interprofessional hub, teaching, mentoring, connecting with an interprofessional group of spokes. The spokes are these members of the community. So this is a summary of our cycle. Our cycles have around 22 sessions. So when a person finishes one cycle, they can start again. They don't need to start on the first session. They can start in the middle of this cycle, and then we tell them, if you attend 22 sessions, you will see all the didactics, and these are the topics of the didactics. But people attend as many as they want. If they want to attend less, they do. If they want to attend more, they do. We also have what we call boot camps, which are more like skills-based workshop. Unfortunately, we had to cancel the December boot camp because of COVID, but we have had every year. We bring these spokes who attended ECHO the whole year. We bring them to Toronto for a more like a skills-based training. Like we do demonstrations of injections, physical examination, we do role plays, how to do, how you talk about urine drug screenings, how you do a clinical interview, how you do a qualitative sensory exam. And so they like, because they spent 2 days with us learning more like a hands-on approach. In terms of research, I got a CIHR grant to evaluate the implementation of our grant, of our ECHO. So we just finished our 3-year cycle of CIHR, and this was our framework. We decided to do research with the primary care providers who attended our ECHO, but also patients that were treated by those primary care providers. So I'll show you a little bit of the results that we have so far. So we published a paper describing our ECHO program, and that was our first paper that we published in 2015. And this was the first evaluation of our pre-post questionnaires, because when a person signs up for ECHO, we ask them to complete ECHO questionnaire. And when they leave, when they inform us that they are going to leave, they're not coming anymore, we send them the post-ECHO questionnaire. So we compare pre and post. And this is what we found. And we divided the group into the prescribers and non-prescribers. So this is the self-efficacy scores. They improved both in the prescribers and the non-prescribers, pre and post ECHO. This was the knowledge scores, pre and post ECHO, again, by prescribers and non-prescribers. We noticed that there was a significant improvement in knowledge related to chronic pain. This was the satisfaction and acceptability of ECHO. We had to do a lot of this because we were the first ECHOs in Canada, and a lot of people asked us, what if it doesn't work? Should we continue funding you? How do we know if it's working or not? So we had to do a lot of research to demonstrate that is this achieving the goal that had to achieve. So this was a satisfaction survey of people who attended ECHO, and we know based on this, some things the satisfaction was low, like 67, because of course we're not going to reduce variation in care, but we were able to make their time, the time involved, it's a lot. We asked them to come every week, 90 minutes during the lunchtime. If people are coming back every week, we don't pay them to be there. It's because they're getting something out of it. So it shows here that they get something out of participation in ECHO. This was exciting because this was a master's student that did her master's looking at opioid prescribing in Ontario using the ICS database, which is the monitoring system in Ontario, the prescription monitoring system. So she looked at patients. We asked the family physicians to give us consent to look at their patients. So this is the blue line is, and this is, I only brought here the graph that shows the high dose prescribing. So the family physicians, they had to have at least one patient on opioids. And then we looked at all the opioids, and we looked at the high dose opioid prescribed. So these are all the patients that they had that were on high dose, more than 200 milligrams of morphine equivalent a day. So the blue line here, 348 patients from the people who attended our ECHO sessions. The average 6 months, and the orange line in the middle is when they started attending ECHO. So you see that the blue line, or ECHO participants, were prescribing more than 50% higher the dose of opioids than the two control groups. The red control group was a matched control, 2-to-1. We had 2-to-1 matched control, matched for geographical area, sex, number of years of experience, where they were in Ontario. And the green line is the control group of all physicians in Ontario. So we had, of all physicians in Ontario, there were 26,000 patients who were getting high-dose opioids. But we recruited, it's interesting because the ones who came to attend ECHO, they were the high prescribers, 50% higher. But you see the line after, it started dropping even before they started attending ECHO. But after ECHO, they were prescribing less than the two control groups, which was encouraging for us that we were able to help them. At least we want to take some credit, not by what they did before they joined ECHO, but after ECHO, we helped them to continue decreasing the opioid prescribing to high-dose patients. We also did qualitative research. We did quantitative and qualitative research. So we did focus groups. When they came to the boot camps, we always invited them to the focus groups. So we published a paper on interviews with the primary care providers and focus groups. And I will read this quote for you because this was a family physician in rural Ontario. And what this person said, I would say that my chronic pain patients, I don't have a huge number, but they're the most challenging patients, and I've got their faces in my brain. My top 3 probably take more brain and mental energy than the next 500 most challenging people. I often feel helpless. They had seen all the specialists, and the specialists had sent them all back to me with not a lot of help. So what this person said to us was that the participation in ECHO was really helpful for her or him to provide care to those patients who were very challenging. This was another study. This was a qualitative interview studies, and we showed that the motivations of healthcare professionals attending patients with chronic pain and attending this telemetry was also to all the knowledge that they get from other interprofessional care. So they were saying in this paper that they had no idea what a pharmacist, a nurse practitioner, a social worker could help for the patients. Like a pharmacist told us, I did not know that occupational therapists could do this. So now they're collaborating. They used to work in the same building and they never talked to each other. And now they are seeing the patients together because they learned that in attending the ECHO sessions. So how do we expand it in Canada? I'll tell you just about the chronic pain ones. BC has done ECHO for chronic pain, and Saskatchewan, they also had done ECHO for chronic pain. And we have another ECHO in Ontario, that is this northern of Ontario, from Dr. Brian McLeod, Patricia Blunt, and Alison Warwick. They are doing ECHO for chronic pain for the northern areas of Ontario. We also have Sick Kids doing ECHO chronic pain for children in Ontario. We have, this is our own ECHO on Thursdays, 12:30 to 2 p.m. And we had Université de Montréal that did with Dr. Lynn Boulanger, who had done some ECHO sessions. And hopefully the next one will be McGill University doing ECHO sessions for chronic pain. So this is how we expanded. Thank you very much. This is the end, and here's my contact information. If anyone would like to contact me, don't hesitate. You can reach me anytime. So I'll stop sharing my slides.